Good evening. My name is Robin Keene, and this is my blog regarding the week 3 assignment for leadership skills. After reviewing the organizational chart for the hospital where I work, which is Central Regional Hospital in Butner, North Carolina, it's one of the 4 state psychiatric institutions. Um, I was able to determine that the organizational structure is a vertical structure and the overall hierarchy or arrangement is vertical. This is pretty typical for a hospital because of the scope of responsibility and the diversity of the work. Um, Many hospitals are set up with a vertical structure. Um, the vertical structure actually provides the parameters for regularly assigned activities, written directives, policies and procedures that guide behavior of your employees, that type of thing. And the vertical organizational chart also outlines the hierarchy from where I work, the Department of Health and Human Services, down to the Division of the State Operated Healthcare Facilities, and then down to Central Regional Hospital, where at the top of the chart is the Chief Executive Officer, and then goes all the way down to like our certified nursing assistants, which at the hospital where I work, we call them therapeutic support specialists. And so it is a vertical hierarchy. Now, the hospital also operates on a matrix model as well, and this is based on organizational levels of the patient care unit. So um, we have patient care units that are by certain areas, like we have the adults unit and we have child and adolescent, we have medical, geropsychiatry, we have a rehabilitation unit is like our continuing care unit. So each of these units have a certain number of patient care units on each one. The adult unit actually has 7 patient care units, whereas Gero has 3. And so depending on the amount of the population in our given geographic area and number of patients we receive, some of the units have more patient care units than other. But when I'm talking about the matrix, basically each patient care unit has a unique interdisciplinary team, and that would include like the clinical nurse manager that supervises all 3 shifts of the nurses, the RNs, LPNs, and the CNAs, the psychiatrist, the social worker, the psychologist, recreational therapist, pharmacist, um, someone from the psychosocial liaison, medical providers, residents, medical students, all of those different people. So the model of care delivery for each patient care unit um, is a model that utilizes the transdisciplinary collaboration. And so there's an interdisciplinary team of folks that always is working together on the plan of care for our patients. So that is one of the models that we use at the hospital, that's part of the matrix model. So we have a vertical hierarchy for the structure, and then the matrix model that we use is more of an interdisciplinary approach. The interdisciplinary approach also that we use is the team approach, and it is a flattening um, approach where everybody on the team is considered an equal and important part of the team, meaning that we don't have the psychiatrist at one level and say, oh, he's the most important part of the team. We have the CNA, the RN, the LPN, the pharmacist, the medical student, everybody that's on the interdisciplinary team that works on the plan of care. We all have a voice, and all of our voices are just as important as anyone else's. Now, even though the CNA might be at the lower end of the spectrum, the CNAs actually are the ones that spend most of the time with our patients because they're doing one-to-one observation, and they're actually doing the accountability 24 hours a day of our patients and making sure that they're safe. So their opinion and observations are relevant and just as important as the ones that the physician The psychiatrist might see the patient for a 15 or 20-minute interview, but the CNA may have spent the last 8 hours with the patient. So everybody's considered to be an equal member of the team, and that's part of that interdisciplinary, transdisciplinary collaboration that we do on each patient care unit. So all of the disciplines will discuss their observations, their assessments of the patient, and this serves as a guide to help us develop the plan of care. And the plan of care is actually a living document that's always in flux and being evaluated and updated on a day-to-day basis. I currently work in a position as nurse consultant. So my position is on the acute adult unit, and I provide guidance and expertise for 3 of our patient care units on the adult unit. We have 7 units, and I work with 3 or 4 units at a time, and then the other nurse consultant does the other half of the unit. And so we share that responsibility. There's 2 of us assigned to the adult unit. So in that capacity, I do sometimes go to some of the treatment team meetings and offer expertise. If we have a patient that has particular needs, that maybe they've had some kind of special treatment team meeting because they have behavior issues that they need a special behavior plan, or maybe they have medical issues that are very complex that require us to have a special treatment team meeting. And those kinds of situations, sometimes I get called to the unit to meet with our team. Also, I work with our nurses. I do a lot of auditing of the nursing process. So in that capacity, I go out and I educate our nurses. So my position prior to working as a nurse consultant was as a clinical nurse manager on the acute adult unit. So I was one of the managers on one of the PCUs on the unit. And in that capacity, my leadership skills were used differently. So when I completed the leadership skills questionnaire, I identified that I have very high administrative skills and high interpersonal and conceptual skills. So as a clinical nurse manager on the PCU, I had to use effective verbal and written communication skills in order to be able to effectively manage the milieu on the patient care unit, supervise the other nursing staff, the RNs, the LPNs, and the TSSs, assess and enforce any policies and procedures, interact with the risk managers and patient advocates, interact with the interdisciplinary team regarding the patient's plan of care. It was my responsibility to facilitate positive morale on the unit among staff and help to foster team spirit or a team attitude. I also had to encourage staff to pursue their education. I was able to help with educational leave if somebody wanted to pursue a higher degree, and encourage them to do that so that we could, whenever possible, promote from within our own unit or our own facility. I had to serve as a role model for positive interactions for our patients and inspire them to either display better coping skills or living skills, or just to display appropriate behavior. One of the biggest challenges was staffing the unit. That's what I spent a great deal of my time doing. And sometimes that would involve, interviewing and hiring people. It would also involve calling other units to see if we had a lot of one-to-ones on the unit and our staffing ratios or acuity was high, then I might have to call other units and ask if people wanted to sign up to do overtime. Sometimes I would have to mandate that our own staff had to stay and work the next shift if we had a lot of call-outs, or I may have to mandate coverage for the upcoming weekend if we had a high acuity and we had a lot of one-to-ones. We might have to have additional staff to cover it. So a lot of my time was spent with staffing. I had to make sure that I was utilizing a good record or log of who was the person that was mandated to work or held over to work overtime in the last time, so that it was something that people want to make sure that we're doing it on a fair basis, that we're not always mandating the same people all the time. We had to keep clear and concise records to make sure that everyone feels like they're being treated fairly. I often utilize the nursing process in my daily interactions with staff and with patients as well. And, that involved assessing, diagnosing, planning, implementing, and evaluating the plan of care. Or it could have been that I was doing the same thing as far as evaluating work performance. In my current position, like I said, I'm a nurse consultant. I do a lot of auditing of the nursing documentation, and pretty much all the documentation that the nurses enter into the electronic record, those are things that I audit. And then I will look for system errors or repetitive errors, any kind of errors that look like there might be a pattern to the type of error that's occurring, and we look at system issues to see if there's something that we need to look at with policies and procedures. And then if we have a repetitive issue where the same person's making the mistakes, then we want to look and make sure that they're following all of the safety mechanisms that are out there, especially with medication administration, to ensure that we don't continue to have those same mistakes. And so I spend a lot of time with doing re-education to make sure people are up to date, not only with our policies and procedures, but with the state regulations as well. I also serve on several hospital committees that evaluate the systems that we have in place currently. I'm on the Falls Committee, the Nursing Retention and Recruitment Committee, and the Treatment Plan Committee. And when I go and I'm a representative from nursing on these committees, there are representatives from all disciplines in the hospital. It is from all disciplines and from all units as well. So we will have representatives from all the patient care units, but we also have representatives from all departments, such as psychiatry, medical, social workers, psychology, pharmacy. We'll have people from occupational therapy, physical therapy, risk management, administration. Somebody from administrative personnel would come. And so all of these folks will get together, and we look at, like for the Falls Committee, we would look at the number of falls that are occurring on the different units, and we would look at our falls protocol, and if it's being followed, are there any changes that we need to make to it? Are we having a certain type of fall that's consistently happening? Is it in the bathroom or in showers, or is it in the treatment mall, or different things like that? And so we look at all of the different factors and see how can we make our policy better to prevent falls. Let's see. If I were to move up the chain in my position that I'm in now from nurse consultant, the next level up would be hospital-wide nurse consultant. And so my job then would entail educating other nurse educators and other nurse consultants, and making sure that I would be supportive and mentoring to them, as well as helping other nurses on the units and being on the committees and so forth. So it would be similar to the job I'm doing now, but it would be incorporating all of the other educators and consultants as well. So let's see. I talked to you about the current hospital organization as a vertical model and the PCU matrix model. They're both, I feel, extremely functional, and it's as far as whether or not they would be my preference or not, or recommendation. I believe that it is a good fit for our hospital. And the article that I looked at was entitled "Restructuring Academic Health Centers to Advance Interdisciplinary Collaborations, Opportunities for Psychiatric Departments." And this is an article that I got from, let me see, what was the name of the journal that I got the article from? I'm sorry. So the article is actually from Academic Psychiatry, and it's from an issue from March and April of 2013. And it talks about how healthcare reform initiatives have highlighted and stressed the importance of interdisciplinary teams, and especially in psychiatry. And I work at a psychiatric hospital, so I found the article to be of interest. And basically, it talks about how the Institute for Medicine identified that this is something that we need to start looking at and educating towards, so that when people go to nursing school or they go to school to become a psychiatrist or what have you, that we actually are teaching in this model, not just utilizing it in the hospital, but actually teaching it. And so the recommendation was is that we needed to start collaborating with institutions and with colleges to try to help people as they're coming along become familiar with it, so that that's something they can utilize when they get out into the workforce. But the Institute for Medicine actually found that in a lot of rural areas, rural healthcare areas, that this is something that could really improve health care in the rural areas, rural communities. And so it's an interesting article, and the Davis Medical School and Hospital is where they they did some of the testing in California, and some of the research was done, and reforms were made, and they felt that academic health centers would be well positioned to help be leading in the healthcare reform area by doing these type of advancements with interprofessional approaches in school and out of school. Um, so that was a little bit about the article that I read. It went on to list some of the benefits and some of the complications as well with this type of thing. But basically, it found that the interfacing of disciplines and professions would be the biggest payoff, and it would be something that would be better for patients as well as communities. And this is something that we already practice. Like I said, where I work, we already do this approach on the patient care units. We do everything by interdisciplinary planning sessions. And when we meet with our patients in treatment team meetings, all of the disciplines are there and meet with the patients together. So we don't actually have a treatment team meeting unless we have all disciplines represented. That's just one of the rules for treatment teams at the facility where I work. And I think that's all I was going to share with you guys. Anyway, thank you.